Hello and welcome to the first episode of a two-part conversation series taking a closer look at the arthritis condition Axial Spondyloarthritis, or axSpA. I'm Gráinne O'Leary, Chief Executive of Arthritis Ireland. axSpA is a painful chronic inflammatory disease that primarily affects the spine and sacroiliac joints. While much is understood about axSpA, it can sometimes be difficult to find accurate and reliable information. During these conversations, we will speak with medical consultants and specialists, providing you with some well-researched answers to common questions asked by those diagnosed with axSpA. I'm delighted today to be joined by Dr Barry O Shea, consultant rheumatologist from St James's Hospital in Dublin, who has a special interest in axSpA. Hi Barry, and thank you so much for joining us today.
Hi Gráinne, thanks very much, and thanks for inviting me to talk about my favourite condition.
Yes, and I'm going to start off by asking you, what exactly is axial spondyloarthritis, or what we'll refer to in this interview as axial SpA, just for short?
Yeah, well, and it's sometimes hard to explain this accurately, what exactly that is, but in its simplest form, axial SpA is a form of inflammatory arthritis. It predominantly affects the spine and sacroiliac joints, and that results in a lot of pain and stiffness that can affect any part of the spine, right down over your sacroiliac joints, and people feel that a lot over their buttocks. In addition to that, they can get a lot of peripheral symptoms, so joints may be involved away from their spine, so it might be ankles or even their knees or feet, but it's mostly spine symptoms that is the major issue. Frequently also get a number of other what we call extraspinal, so away from the spine symptoms. They're at increased risk getting conditions like psoriasis or maybe inflammatory bowel problems, and even an unusual eye inflammation condition called uveitis.
Okay, and in terms of, I know that it can sometimes be seen as sort of an umbrella term for a number of different conditions that fall under this term of axial SpA. Can you tell us a little bit more about that?
Yeah, you're absolutely right. So we try and think of it now, as you say, axial SpA as an overarching term to describe every phase of this condition. People might be familiar with an older term, Ankylosing spondylitis, or AS, and that refers to people that have established spinal involvement. The ankylosing part of it, stands for fusion. So it's people that have had symptoms for many years. But that term really let us down when we were trying to find earlier people that didn't have the fusion in their spine, so people in the first few years of their conditions. So we took a step back and said there is a phase where people before their x-rays become abnormal, and sometimes you might refer to that as pre-radiographic. So the pre-radiographic phase, and frequently we use MRIs and different methods of assessing those people to show up inflammation. So the pre-radiographic phase is the earlier phase, and there is then a progression over time to what we classically would have referred to as ankylosing spondylitis, or the radiographic or the x-ray phase. But if we take a step back and just want to include early and late disease, axial SpA or axial SpA covers all of that.
Okay, and for people who might be watching this, in your introduction you mentioned some of the signs and symptoms of the disease, but can you just let us know, are there any other signs and symptoms, for people that are maybe experiencing back pain out there who are watching this and wonder, do I have this? Like what are the traditional signs and symptoms of axial SpA?
Yeah, you're absolutely right. I mean, back pain is so common, and
sure,
the vast majority of people that have back pain don't have axial SpA.
And most people will experience back pain at some stage of their life. So.
They will. I think it's the most common reason to present to your primary care or family doctor. So, but yeah, remember, it's an inflammatory condition, and inflammatory joint conditions, whether they're in your back or any other joint, have a particular pattern. So if you've got a lot of early morning stiffness, like that, not just a little bit stiff in the morning, but significant early morning stiffness where it can take 30 minutes or 60 minutes or 90 minutes to get going in the morning. And if you've got back pain that improves with activity, you're the person that's better moving around. You hate staying still, you hate sitting in the car for a long drive, you hate sitting in the bus, you even hate sitting in the waiting room, because you're much better off moving around. So if you're the sort of the back pain that gets better with movement, gets worse with rest, that might go down into the buttocks. Remember I mentioned those, so that's where the sacroiliac joints are, and we think that that's where things start. So if it's that sort of pain, and that's very different to more standard back pain. People that have more standard back pain, maybe from disc problems or strain, they love to stay still because it helps them, and they hate moving around. It makes things worse. So it's really the opposite of that. So that's what we call inflammatory back pain, and that what we think of as is the cardinal symptom of people that have axial SpA.
Okay. And how common is it, and who gets it?
You're right, it's not common. As we said, there are a lot of other causes of back pain that are much more common. In fact, there's research saying that of all the back pain patients that go to see GPs, go to see primary care, maybe only 5%, so that's only 1 in 20 of those back pain patients turn out to have axial SpA. So it is rare. And then we look at how common is it in the population in general. Again, it's hard to get very detailed information, but it's less than 0.5% of the population at large will end up having axial SpA.
Okay. And do we know what actually causes it? You know, and are there known risk factors, for instance?
So, like a lot of our conditions, there is a genetic tendency in them. So people are predisposed by their genes. But not everyone in a family, even though they would have the same genes, would get the condition. So something else must come along to trigger it. A lot of our inflammatory conditions, our autoimmune conditions, are frequently triggered by, we think maybe a viral infection might be what triggers someone that's predisposed. But we never know for sure, because sometimes it's so hard to date back to when the symptoms actually really start. So then it's even harder to remember, was I unwell in those few months beforehand? But basically the bottom line is people are genetically predisposed, and then some environmental trigger is enough to tip them over at the edge and to start to develop inflammation, and that inflammation builds up in their spine and they start to get back pain.
And I mean, sometimes people tend to have a belief that this form of arthritis has more of a genetic component than other types. Is that fair to say, or is it just a myth?
No, that is fair to say. I mean, compared to some of our conditions, it would definitely have a stronger genetic component. You're even able to follow it more closely to various family members. It's not a condition that's passed directly generation to generation consistently. But if you look, are able to plot out even kind of family tree, you'll be able to see different family members that are affected with the condition. Or interestingly, some of the related conditions that I mentioned at the start, like maybe psoriasis or inflammatory bowel problems, they are all genetically linked. They're not the exact same, but they're very similar. So you might be able to trace back going that it was an uncle that had inflammatory bowel problems or a grandfather that had psoriasis. So there's the related conditions all run down through families. Yeah, back to your point, I would say it has a strong genetic component. So yeah, compared to some of our conditions, definitely.
And I think just linked to that question around who gets it and how do people get it, I've often heard it said that this is one of the few types of arthritis where it's more prevalent in men. But I know that there's been some sort of further research done on this when you look at the broader Axial SpA family. So can you tell us a little bit more about that for people watching?
You're absolutely right. I mean, I suppose classical, or what we're trying to think of, a historic Ankylosing, so that version that maybe is more severe or has that kind of fusion and a lot of spinal involvement, that definitely is seen in more men than women. Now, we used to think it was very much tipped in the favour, maybe 10 to 1. We know that that's actually not correct. But it's still roughly maybe 3 times more common in men than women. So that's the X-ray phase. But as I say, we're now starting to step back and look at this group so we can capture both early and late disease as a more better terminology. So the Axial SpA group. And the gender difference in those is actually the same. So you're as likely to, men and women are as likely to get it. And this has been, with the change in the terminology and the change in our criteria over the last few years, this has been really interesting. So a condition that we previously thought of as maybe being very rare in women, we actually know that that's really no longer the case. They're every bit as likely to have this version of it. And that's important. Our thinking very much has taken us down that this is a predominantly male condition. So it's certainly important that we start to redress that and start to think of it again. And historically people were even slower to diagnose it in a woman.
Yes.
But we know that there's every chance that the patient in front of you, whether it's a man or woman, could have this condition.
So when it comes to diagnosis, moving on to that, can you take us through the steps to a diagnosis? How exactly is it diagnosed?
It can be challenging. It can certainly be challenging in the early phases. At the end of the day, it is what we call it's a clinical diagnosis. You come into my clinic or anyone else's clinic and they have to use their clinical skills and clinical judgment to make that diagnosis. We have lots of tools that we use, whether it's blood tests or x-rays or MRI scans. But at the end of the day, we need to, what is the likelihood that someone coming in has this condition? So back to what we started off with describing that pain, the first thing I take is a history. I want the patients to describe their pain for me, and it's so informative when people start to describe it, because you get clues, this bad stiffness in the morning. Even frequently they wake in the second half of the night, because remember, they've gone to bed and the inflammation has built up as they've been still. Remember, these patients hate staying still. Yeah. So the inflammation has built up in the second half of the night. So they, from 3, 4, 5 o'clock in the morning, frequently have to get out of bed. The pain is that bad. So people start to describe that. That's a warning sign. That bad stiffness in the morning, they tend to be better if they're moving around. They hate staying still. They might have tried various anti-inflammatories, and it is an inflammatory condition, so not surprising, anti-inflammatories will help. So it's when I listen to the history, when people describe their pain, I have a suspicion that it either is or it isn't. And then we start the process of trying to investigate them. It's relatively easy to get plain x-rays, so we frequently start with those. And if people have had symptoms for a long amount of time, their x-rays may start to show the classical changes of what we've previously called ankylosing spondylitis. And great, that's their diagnosis made. But as I said earlier, those changes don't happen at the start, and we would miss them if we only had those plain x-rays. So in patients that I think might have an underlying axial SpA, I am convinced, or as convinced as I can be, that it might be, they're the ones I would at least strongly consider sending for an MRI. And the MRI has helped us a lot. It's really important that we get the right type of MRI, because again, we are looking for inflammation, and there's a specific kind of type of MRI that's done. It's done in the same machine and all the rest of it, but the request needs to specifically please outrule or confirm inflammatory changes in the spine or sacroiliac joint, because a standard MRI won't necessarily do that. And then once that MRI is done and it's the correct one, and in the setting of, we frequently do some routine blood tests, because the inflammation markers can be a pointer. If you're in good health, your inflammation markers should be normal. If you've got chronic inflammation, those markers that we use, the CRP and the ESR, they're called, will start to raise. So it's bringing all those together, and then at the end going, do I think you have an axial SpA? Yes or no?
Okay. And I know this is one of the diseases within the rheumatic disease family that can sometimes take a long time to be diagnosed. And, I think, correct me if I'm wrong, but it can take up to 8 years. I think that's one of the things, and it's certainly one of the rationales behind doing this campaign. So, why can it take so long to be diagnosed?
Yeah, you're absolutely right, and it's so frustrating. We wouldn't find that acceptable in so many other conditions, even in our own field in rheumatoid arthritis, that you might wait 8 years to get your diagnosis. So why is it? Remember, the presenting symptom is back pain. Yeah. And we've said already that only a small percentage of back pain is inflammatory. So only a small percentage of back pain patients have an axial SpA. So that we're up against that from the word go. So as I said earlier, for back pain patients maybe presenting to their GP, only 5% of them, so 1 in 20. So a GP will have to see amongst their busy practice, lots and lots of patients, but also lots and lots of back pain patients, 19 out of 20 before they might stumble across the one that has it. So it's hard in that, therefore it gets lost somewhat in regular back pain.
Yeah, they're not seeing too many cases.
Absolutely, and a lot of people even themselves don't necessarily seek out attention with their back pain. They're like maybe to go directly for physio or start to do some some exercise or swimming themselves and stuff. So each of those steps delays things a little bit. Yeah. And I suppose the other major reason is that our older criteria were not very good. They were dependent on x-rays, and they were dependent on x-rays showing up classical changes in the spine or the sacroiliac joint, and they don't happen early. So even if you happen to come to see me in the first year, and that would be good, and I just only did a plain x-ray, your x-ray might be normal, and I might say, well, you don't have an axial SpA. Off you go, or go back to your GP and things like that. But you could well have done.
Yeah.
So the advent of newer criteria and the advent of newer technology like MRI, plus just increasing awareness, that's why this is so important, increasing awareness that every healthcare professional thinks of this condition, from GPs to physios to doctors working in the hospital on the general wards, and even rheumatologists. The more we think about this condition, the more likely we are to diagnose this, because we have to work so much better on that. You're right, it's over 8 years is the average delay from your symptom onset to coming in and being told you have the condition.
So we've covered diagnosis. Then let's move on to treatment. How is axial SpA treated?
Two main broad categories are the way we divide it, is the non-pharmacological, so non-medicine side, and the medicine side, the pharmacology side. And the non-pharmacological side is really, really important. I think of all the conditions that I look after in rheumatology, it's the most important. It is so important. Remember, this is a condition that's potentially going to involve the full length of your spine, and we've seen in the very severe versions of it going to fuse your spine. So we want to do all in our power to reduce or eliminate that as much as possible. I work really closely with physiotherapists in my clinic, and anyone that has a new diagnosis, they automatically get referred to the physiotherapist, because it's so important that they have a specific kind of tailored program for them and their back, that they keep moving it, they keep stretching it, they keep strengthening it, working on their core strength, all these things that are really, really important. And what falls into that as well is keeping your weight under control. And the more pressure that's put on your spine, the worse it is. And just educating yourself about your condition and all the things that you can do non-pharmacological. We don't always have to depend on medicine. It's only a small percentage, but I have some patients who don't need any medicine at all, but they have a very strict exercise program. They're the patients that might go swimming 3 or 4 or 5 times a week. And that's enough to keep their inflammation under control. So that side is important and crucial. And then we move on, and then I'm more responsible then on purely on the pharmacology or the medicine side. Like the first line treatment for this group of conditions are anti-inflammatory medications. And it is really important that you try different anti-inflammatories. There's lots of them out there, some of them across the counter, some of them are on prescription. And I always get people to try different ones, because everyone is a little bit different in terms of how they will respond to a medication. And anti-inflammatories aren't the cure for everyone by any means, but there's a cohort of patients, maybe about a quarter of patients, and they will be enough, whether they need to take them regularly or maybe on demand, but that will be enough to control their inflammation. Now, we don't necessarily like people being on those anti-inflammatories long term, day in, day out. They're not without their side effects. So we are conscious of that. And I suppose how things have changed in the last 10 or 15 years is the advent of the biologic medications. So that's another group of medications. They work against inflammation in a different way than an anti-inflammatory. They're much more targeted, they're much more specific. Classically, they block a central cytokine called TNF, or tumor necrosis factor. And this seems to be so important in the inflammation in your spine. So if you come in and you block it, it has a significant impact on people's level of pain and stiffness and inflammation. They're normally able to reduce or even drop their anti-inflammatories completely, and they stay on these medications. They're slightly different to the anti-inflammatories. They're not given by tablet, they're an injection that people normally give themselves, but people get used to that very quickly. And thankfully they're not very frequent. There's different versions. You might take your injection once a week or once every 2 weeks, or maybe even once a month. So that works very well, and they've really been a game changer in terms of how we treat this group of conditions. So that's broadly how I start to kind of come up with a treatment plan for any patient that comes into my clinic. Okay.
And like we know with any form of inflammatory arthritis, flares and flare management can be, you know, a really important part of the, I suppose, as the disease develops or as people live longer with it, you know, it just seems to be part and parcel of the whole process. Can you explain first to people watching, you know, exactly what a flare is, and then how it might be managed?
Yeah, so I suppose this condition isn't any different than any other condition that, you know, that will go through flares or attacks, and people call it different ways. And it's just for whatever reason, a significant increase in their level of symptoms. People may already be on an effective treatment that's controlling them 90% of the time, but something happens and they get an escalation in their level of symptoms. We don't really understand that, like why you might get a flare. You know, is it if our body comes under some form of stress, and that can be physiological stress. You might be, you know, having another illness, and that might be enough to trigger, or even psychological stress might be enough to actually trigger an attack or a flare, and just their level of symptoms will increase. So they might have been doing fine, but all of a sudden they wake up one day and they nearly get a reminder of what their symptoms were like before they started treatment. It's important that patients know that this is common, and it is manageable, and that we can, you know, very easily come up with a plan for that. If people are on an established treatment, say they're already on one of their biologic injections, it just means as a short-term measure, we need to escalate things to bring that inflammation back under control. So I would frequently put people back on their anti-inflammatory medication, maybe for a couple of weeks, just till things settle down. It's totally safe to take your regular biologic injection and to come in with an anti-inflammatory. They work in a totally different way. They are safe to use together. And I get them to re-engage with their physio or their exercise program. I get them, if possible, if there's something not too bad, to say get into a pool, because it's so much easier to kind of ease out the kind of the tightness. A lot of patients, when the inflammation builds up, they get their muscles almost go into spasm, and they can get a lot of symptoms throughout their spine. And the warm water of a pool does wonders for that and stuff. So it happens, hopefully not too frequently, that people get a flare if they're on effective medication. But if it does happen, people need to know that we have a plan for that. And it's normally reverting to anti-inflammatory medications would be the most common.
Okay. Is surgery often needed?
Not that often is the short answer to that. I suppose you need to remember that this is a condition, it affects really the length of your spine. It starts right down over your sacroiliac joints. And where we think things actually go wrong are surrounding our spine and our vertebrae are a series of kind of tendons and ligaments up and down the length, and keep us upright, keep us together, but keep us flexible. And it's where those tendons insert and attach to those vertebrae that each of those little points becomes inflamed. If you think of them, we'd have 30, 40, 50 of those points that potentially would become inflamed. And that's why the symptoms can be so severe during a flare. But operating on that really isn't an option. There are multiple levels. So in terms of for the active inflammation, we just don't send patients for surgery on their spine. We do need to remember though, as I said, it's a condition that predominantly affects the spine, but it can affect other joints like hips even, or knees. So there may be an increased risk of getting more wear and tear on those joints. So Axial SpA patients may end up getting, you know, a hip replacement or a knee replacement at maybe a slightly younger age than someone who didn't have that condition. So that's the sort of surgery that I most frequently would end up sending my patients for, rather than directly on their spine.
Okay. When it comes to the person themselves getting involved in, you know, how they manage their condition, you know, what can a person do to help manage their axial SpA, and what can they do to manage their pain?
I suppose the first thing I would say is you need to be knowledgeable about it. You know, it's your condition, and you need to learn about it, become educated about it, and also listen to your body in terms of how your symptoms are. And certainly if you've got a certain level of symptoms and all of a sudden they change, that's important. And not just automatically going, oh, this is just the way things should be. You know, if your pattern of symptoms change, that, you know, something needs to be done about that. So learning about your condition is crucial from that point of view. As I said earlier, the work in some sense that you put in terms of exercise really pays dividends. It, you know, exercise and those things are good for all of us, and both our mental well-being and our physical well-being, particularly for Axial SpA patients. It keeps their weight under control, so anything you can do, keep your weight under control. The less amount of weight that this spine is carrying, the better things are going to be. So that's the things that I always say. If patients happen to be smokers, hopefully they're not, but I strongly emphasize that that smoking needs to go. All the data out there shows us that patients, Axial SpA patients, do worse if they're smokers. They're less responsive to treatments. they are more likely to progress at a quicker rate than the non-smokers. So that is something that they can directly take control of, it, if at all possible, and address.
Is smoking also a potential trigger for the development of axial SpA in the first place?
It is. I mean, smoking is bad for 100 different reasons. We all know that. But in the rheumatology world, in different forms of arthritis, back to what I mentioned earlier on about what potentially is a trigger. Again, if you're genetically predisposed, smoking can be one of those triggers that kind of pushes you over the edge into starting to develop the symptoms. We know that for definite in rheumatoid arthritis, but certainly in axial SpA as well, that is likely to be the case. And it just, all the data would show that you're going to be less responsive to treatment. So that's why that is so important.
Okay. And I'll move on to asking you about sort of diet and nutrition, because obviously this is a pet subject for lots of people with arthritis, and certainly in relation to axial SpA, this would be a question a lot of people ask as well, in terms of, are there certain foods that a person should exclude from their diet or anything like that? So as the expert, what research is out there to support, the influence of diet?
Yeah, like you're absolutely right. It's probably the question I get asked the most, because I mean, it, in lots of ways, it seems like a great thing. Going, oh, if I take tomatoes out of my diet.
It's something you can proactively engage with and make changes.
Unfortunately, well, back to your point, the research on it has been poor. So there's not great research on the role of diet. But what we do know is that the standard advice about a healthy, balanced diet is crucial, because that will have such a role in keeping you at a healthy weight. Being overweight is, again, because of just the physical impact on your spine isn't good. But carrying around extra weight is not good in itself. That tissue is very, what we call, pro-inflammatory. So it's another stimulation for inflammation. So lots of reasons to follow a healthy, balanced diet to get your weight under control. Specific things then that we're starting to learn about now is the role of processed foods, and particularly processed carbohydrates. So the more processed a diet is, and the more processed our carbohydrates, so very much if it's a white bread, white rices, white pastas and stuff, that sort of processed food stimulates inflammation itself. So if you've got an underlying condition or in any way predisposed, there's another trigger that's going to come along. Now, we're not saying for any means you cut out your carbohydrates altogether. It's all about moderation and stuff, but trying to cut back the processed intake in your diet just into a healthier diet is going to remove some of that stimulus for inflammation. So that is something that patients themselves can take control of. It's not easy, but at least if they do it the majority of the time, I think they'll see a benefit from it.
Okay, and I suppose just looking to the future, I know you don't have a crystal ball or anything, but in your opinion, what does the future hold for axial SpA? And can you tell us a little bit about the research that's going on in this area as well?
Yeah, I mean, I think personally it's very exciting. There's a lot happening, but there's a lot still to be done and a lot of deficiencies in our knowledge about it. The number one thing is cracking the diagnosis and reducing that time that people are waiting, not having them wait 8 years to get their formal diagnosis, because that's, we need to get people started on their treatment plan and their goal. And all the evidence that does show us that where you are able to identify people earlier, so early disease in the first few years, and get them identified and onto effective treatment, that they do the best in the long term. We know that without a doubt. So that is crucial that we focus on reducing the time to diagnosis.
And what do you think are the elements of that?
I think things like this are important. I mean, I think educating patients about back pain, and that there's a chance that their back pain might be caused by something different. Healthcare professionals have a role in this. We need all across the board to improve our awareness and to think about it. If we don't think about this condition, we'll never diagnose it. So I think all those things are important. The change in terminology, even though not ideal and it's all a bit of a mouthful, at least dropping ankylosing spondylitis to some degree and replacing it with axial SpA, at least it's the same letter, so AS. So sometimes people refer to the condition as AS. They get to keep their letters. It's great.
Yes.
And so that's all part of it and stuff. But there are still, as I said, kind of deficiencies in our knowledge. And particularly, I suppose, the gender difference is so important. Our females patients have been poorly researched, because I suppose it was poorly or rarely thought of. This condition didn't really affect females. Why would we think about pregnancy? It hardly ever happens. Happens a lot. Half of the patients now diagnosed with axial SpA are women. So what about the effects of pregnancy and all those sort of things? So they're really important, and they're a focus of ongoing research, but there's a lot more work to be done in that area going forward. So they're the main areas that I see changes happening, hopefully, in the next few years. I suppose the other thing, in the same way that treatments have changed hugely over the last 10 or 15 years with the advent of biologics, like that whole field is changing hugely as well. And if you told me, like I started in rheumatology 20 years ago, we'd have all these very much targeted treatments, I would have said, God, that's kind of crazy talk. But it's switched to, it's just moved hugely in terms of, we've a repertoire of treatment now, which is brilliant. And I suppose what will come back, the next phase, hopefully, will be just getting better at picking what treatment do you go on if you come into me. Do our female patients respond better to drug A versus drug B? Should we, if you've got family history, should we target drugs differently? We're not there yet at this idea of a personalized medicine approach, but the changes that we made so much in the last 10 years, that's where we're going. So I don't necessarily waste too much time by just, well, start you on the drug that I've always used and give you a trial, and then wait and bring you back 3 or 6 months later, and if you're no better, I keep on moving. Whereas being able to make that decision on day one or in those early days will be crucial. And I think that's the more research we do about it, the more likely we are to make good decisions about treatment.
Yeah. Okay. On that positive note, I will finish things for today, and thank you very much for being with us here today.
Thank you.
Thank you, Barry O Shea. And thank you very much for watching this video. For more information on Axial SpA, please log on to our website, arthritisireland.ie. You can also get further support via our online Facebook groups or via our helpline 0818 252 846. Thank you very much again to Dr. Barry O Shea, consultant rheumatologist, for joining us and for sharing his insights and experiences. We look forward to seeing you again soon.